So I'm at the ASH annual meeting and happy to discuss some of the key abstracts and findings for aggressive lymphomas. There's two areas that I'd like to address. The first, I think, has been in the news quite a bit, and that is the role of CAR T therapy in aggressive lymphomas. With the recent approval in the United States for the Kite product, I think there is now increasing interest and numbers of patients who are all hoping to undergo this type of procedure. It's important to know that there are several different groups who are also trying to develop CAR T products, and which one of these products will be better, worse, or the same, I think remains a matter of investigation and a matter of debate. I think the big emphasis right now is on identifying which patients will be most appropriate for this type of therapy. And I think what's very reassuring is that across all the different products and all the different companies and investigators, we're seeing fairly consistent results in that patients can go through this procedure safely, many as an outpatient, although I think that point depends on the resources available to the patient and their family, and that the toxicities are manageable. Perhaps one of the most important pieces we've learned as this field has evolved is that institution of supportive care and management of toxicities is best done when the toxicity is at lower grades. So I think the early studies waited to institute, let's say, steroids or tocilizumab until the toxicity was fairly severe. And at this point, instituting it a little bit earlier may allow us to expand this to either more older patients or to other categories of patients and hopefully mitigate the toxicity. The other issue that's coming up about CAR T at this program is just that we are trying to identify which patients benefit the most. And I think something that's emerging is the concept of tumor burden. There's one discussion here, one presentation that showed that using CAR T after autologous stem cell transplant may not be the most optimal site or point at which to introduce CAR T because there's minimal antigen. On the other hand, some of the efficacy seems to be lost if you have a very high tumor burden. So perhaps the next generation of investigations should really focus on identifying that sweet spot of how much tumor burden we need. The other area that I wanted to just talk about is something slightly different, and it has to do with MYC-rearranged lymphomas. I think for many years the management of Burkitt lymphoma, for example, has had many options, and most of these have been very aggressive. That include high-dose cytarabine, high-dose methotrexate, and because of this intensity are limited to younger patients. And what we had seen previously from the National Cancer Institute is that in a single institution study, dose-adjusted EPOCH-R is an appropriate type of therapy, but we had not seen this in a multi-center setting. And so what we saw this time was a multi-center investigation of over 100 patients with MYC-rearranged Burkitt lymphoma, and patients were divided into low risk and high risk. And at least for the low risk patients, it seems that dose-adjusted EPOCH-R without intrathecal methotrexate, with an abbreviated course based on PET adaptation, seems to be highly effective. And so this is something that's very promising for a group of patients with overall a good prognosis, but sometimes intolerance to intensive therapy.